cancers, and every now and again, sometimes these terms might be interchangeable. So luckily this one's a little more specific. We're talking more about the colon and the rectum. So this is the third most common cancer. It usually arises from the epithelial lining of the intestine. Most are in the rectum and sigmoid colon. I'm going to draw a big focus to risk factors. I want you to remember family history of colon cancer is a big risk factor. And we did discuss history of ulcerative colitis, but note, family history of colon cancer is a big risk factor. It says here lack of dietary fiber. Again, that's very controversial. High-fat diets, again, very controversial. More common in men. So if you're a male gender and you have a family history of colon cancer, oftentimes your physician's going to monitor you fairly closely. If on colonoscopy they find polyps, that's also can be a precancerous sign. And over age 50. Now, remember, in the same vein of what we spoke about before, early detection can be hard to achieve in these patients. A lot of times their symptoms can be very vague and non-specific, and oftentimes they can go see their physician and they go, okay, well, we'll just wait and see what happens. But even if it's something as innocuous as changes in your bowel movements intermittently, that could be a sign that cancer exists. So it's very important to pay attention to your bowel habits, your abdomen, how things feel, and report those to your physician if you're worried, because late detection, which is not uncommon, also comes with it commonly already being metastasized to another place or widespread and where it is. Early warning cancer signs, change in bowel or bladder, specifically bowel. We're talking about colon cancer here. Unusual bleeding or discharge. If you have blood on your stool, don't just assume that it is a hemorrhoid or that this does happen from time to time. It should be checked out. Indigestion, difficulty swallowing, kind of honing on the ones that are specific to GI here. Here's another shot from colonoscopy where you can see.
Hey Ron, can I interject real quick?
Yes.
There's a new prescription-only medication called Cologuard, which is pretty interesting. Maybe Ron was going to talk about it, but the idea is that you can get a prescription from your doctor, take it home, get a stool sample, mail it in. It's very good. In fact, I think they've got like a 92% success rate of correctly identifying precancerous issues, and it also checks for blood. And something you want to make sure your customers are aware of, your patients, so that they can do that. A lot of people won't come in to see a doctor. Tell your friends, family, neighbors, because it's embarrassing. They don't want to talk about blood in their stool. But it's important. You can avoid colorectal cancer. Just my 2 cents worth. Go ahead.
Yeah, I think it's a good point, is people are very slow to talk about their bowel movements. And that's cool. I was not going to talk about that. I already mail my poo to people, but it's not medical in nature.
I'm glad to hear you sharing.
Caring is caring. So, colorectal cancer nursing assessments. Signs and symptoms depend on the location of the bowel. That's very true. And if we don't know where it is, i.e. we have a patient who's come in and they're kind of having non-specific symptoms and we have a suspicion that this may be the case, then you might not be able to directly correlate it to your anatomy. But if you have the knowledge of where and what is going on, that can explain your symptoms. You can have rectal or abdominal pain. Like we said, changes in the bowel and the bowel habits. There on the side of the screen, we have a picture of our Bristol stool tray there. Which for some reason, once people get admitted to the hospital, they all jump straight to type 7. I don't know what that's all about. Rectal bleeding, we talked about anemia, weight loss, fatigue, and or a palpable mass. People who have tumors of the bowel, you may be able to palpate it. Ask them to describe their bowel movements using familiar terms: nuts, sausage, pencil, fluffy, mushy. Jumping down to diagnostics, abdominal and digital rectal exam. Abdominal exam, yes. Digital rectal exam, I feel like is less favored. One, you tend to require a chaperone while it's performed, even while the physician performs it. Two, unless it's in the rectum or we know that it's in the rectum, we're not going to feel anything that way. Fecal cold blood tests, barium enemas, proctosigmoidoscopies, flexible sigmoidoscopies, very similar to the colonoscopy there. CT is a great catch-all. Now, kind of what we spoke to last week, CTs, MRIs, PETs are often used for staging because you're not just looking at a localized area. So, when you have this, if you have a colonoscopy, say, you're snaking a camera up the colon, and if you're able to identify a spot, typically you're looking at a localized spot. But when we're able to scan the entire area, we can see how far does this extend. Does it involve any other structures? And it gives us a lot more intel on what's going on. You can also you can look for the carcinoembryonic antigen, and we'll see in other cancers as well that there are some specific lab tests to look for biomarkers that these exist. Colonoscopy saves lives. So here's a good picture of tumor spread and staging, right? So you can see here on the side, you have that stage 0 that's just stuck in that epithelial wall there and isn't spreading out much further. But you can see as you go up in stages, you start to progressively involve more structures spreading further outside the colon and up until we hit those lymph nodes, and at which point things most likely have become systemic, i.e. malignant. I'm going to jump past that. Colorectal cancer treatments. Surgery, if diagnosed early, that way if it's still localized, they can get in there, chop it out, and hopefully have a cure. There are some cancers which can be removed while under colonoscopy, or during colonoscopy. They're able to go in and resect either biopsy tissue and or resect some tissue. Bowel resections, and going back to those designations we talked about, I want you to know what each of those means: partial colectomy, hemicolectomy, and the total colectomy. So familiarize yourself with those terms and the segments of bowel which they involve. Abdominal perineal resection and temporary or permanent placement of an ostomy. It depends on the spread. One thing that has to be considered when they're doing colectomies, when they're doing these bowel resections, is how much bowel is left. And even jumping back to patients with Crohn's disease who have partial colectomies several over time, eventually, even though you do have a lot of bowel, you'll get to a point in which they can't stretch it anymore. At which point a permanent colostomy may become necessary. Radiation therapy and chemotherapy. Remember, chemotherapy for systemic issues. Radiation therapy can be for localized issues, and this tends to be used in conjunction with other therapies so that you're able to resect, say, 95% of a tumor, and then hammer it with radiation and or chemo if needed to be as comprehensive in the treatment as possible. here you can see another picture of stomatites and kind of the segments of bowel which can be affected. One thing I want you to remember is if a patient has an ostomy, that doesn't mean that they don't poop. And also, say here on this right side of the slide where you have a left lower quadrant stoma and the rectum is essentially, or the rectal portion is essentially removed. These patients also can have discharge from the rectum, so don't be surprised if you see that.
Oh, we have a question from Elena.
Diana.
I was wondering if people can have like a colon transplant, like if you had to remove their whole colon, like for a total colectomy, can people get like a colon transplant to replace that?
You know, I actually don't know. It's not something that I've heard of, but I wouldn't be surprised in the current day. They do fecal transplants. But I'll look it up and see.
She's smiling. I think that means yes.
All right. Here, oh, this is just more pouches. Pouches and holes that we put in the bowel. And I'll outline these a little bit. So, did everyone get the email I sent out last night with that had a little bit of a review sheet on it?
Yes.
I can hear you all nodding. Yes. So I'm going to send some more of that out. I'm going to try and get it out in the next day or two on the farm, on this lecture and the farm lecture. Pay attention to anything that's bold or italicized. Wink, wink. Colorectal cancer nursing diagnoses. I'm going to run over this a little bit because there's some things I want to draw your attention to. Pain, namely pain. These things can be extremely painful. These patients can have multiple bowel surgeries. And it tends to be a fairly miserable state of being between having bowel surgeries, having your ability to eliminate waste impaired. These patients can be in a big fluid volume deficit, one from just the general surgery and blood loss, but two, because they may not be able to take in nutrition. I've seen some patients who, have been in PO for, a month and or 2 months because of issues that are wrong with their bowels, and not eating for 1 to 2 months and living off of TPN if it's required, just changes people mentally. It's a really big mind game, can be. And also anxiety. Remember that the patient is a person and not just a diagnosis, especially when we're talking about cancer diagnoses. Anxiety, depression, mood swings, irritability, tearfulness. You're going to see all these things, and you want to try and be as supportive as possible. And supportive doesn't just mean, answering questions about what's going to happen to them, even though in keeping them informed is extremely important, but it also just involves a lot of listening, allowing them to speak their mind. So, Hirschsprung's disease, which is known as congenital aganglionic megacolon. Now, I'm going to draw your attention to that name, congenital aganglionic megacolon. So, aganglionic meaning the absence of those ganglion cells in segments of the colon, i.e. this is that parasympathetic part that regulates how the colon moves. So when you don't have that, what you see is a lack of peristalsis, and when you have a lack of peristalsis, things aren't moving, so that valve becomes dilated from things sitting in it. And then also failure of the sphincter to relax, which prevents evacuation. And in these patients, because that sphincter doesn't relax, you can see diarrhea, which is secondary to constipation, i.e. food sitting and not moving. Now, this is something you see in the younger kids. So this is a failure to pass meconium within 24 to 48 hours. Everyone know what meconium is?
I'm getting blank looks.
Yes.
Okay. All right. Baby poop. Newborn baby poop. Bile theme vomitus and failure to thrive, nutrition, constipation, diarrhea. Because we're not able to mobilize. And you can see here in this little picture how this colon starts to dilate. You got this little pooch belly out there. You know, we stop moving food. We start vomiting, which isn't good, right? It's very similar to what you see in bowel obstructions, but in the children, failure to thrive is extremely important to pick up on. But typically, this is fairly easily identifiable. But if it doesn't happen, say it doesn't set in a young infant, paying attention in the younger child is extremely important. So for Hirschsprung's disease, I really want you to know the physiology of what's going on here. So diagnostic testing for this is anorectal manometry, barium enema, and rectal biopsy. Medical treatment, NG tube to decompress. This is something we spoke about before. We have this backup in the bowel. We're having all this pressure. We want to be able to get some of that pressure out. And as awful as NG tube insertion can be for the patient, which often is quite awful, patients who are having any form of obstructive process in their abdomen and we're able to get, and I've put NG tubes in people and immediately pulled out 2 liters of fluid straight away. They at least tend to feel better a little bit after that occurs. Isotonic enemas, stool softeners, low residue, high protein diet, TPN. We want to avoid TPN if possible, but it is an option, especially if you're going to be NPO for a long time. And then surgery to place a colostomy and or colectomy to divert some of that stool. So as a note, in the biopsy, it's going to show an absence of the ganglion. That's how we diagnose this, right? Here's another photo here showing the colon when it's afflicted by the Hirschsprung's. So nursing care, pre and post-op care, we're not going to go over that again. Eyes and nose, this is something that's important for all patients, but make sure you are tracking how much they're taking in, how much they're putting out, so you know, is what I'm putting in coming out, and if not, how much isn't coming out. Abdominal girth, as we saw in this other photo here, they can have this kind of pooched out belly, and if it's getting acutely worse or better, we want to be able to identify that in an objective way. Just eyeballing it isn't enough on this. And as a note, especially in the younger kids, and I wouldn't say just younger kids, anytime a patient is facing down getting an ostomy placed, you want to try and be as supportive as possible. Some people are very pragmatic about it and they're like, okay, this is what it is and this is okay. But, I have seen people who, need a colostomy and they're like, I would rather die. I'm going to kill myself. And it can be an extremely traumatic process. So remember, you want to be able to care for them and deal with any issues with impaired body image that they might have, and be able to identify any resources which are going to help them not only while they're in the hospital, but after they go home as well. We're going to jump over to helminthic disorders. Helminths, AE worms, roundworms, tapeworms, flukes.
I'm sorry, I'm going to interrupt again real quick.
Okay.
While we were on that previous subject, abdominal surgery, I know a lady who is closing on 60 abdominal surgeries. One of the things you run into, the first time you have an abdominal surgery, it weakens the tissue around the incision. Sometimes the second time they'll put in what they call a mesh, where they try to draw it together, and the tissue of the body actually grows into the mesh, and it helps to support it. But right at the edges of the mesh where they put it in, it weakens the tissue. And you are gonna find patients like that. You're gonna see a bunch of them. It's not uncommon at all. Their abdomen looks like a jigsaw puzzle. And this is an enormous mental health issue. Somebody who spends as much time in the hospital as they spend out of the hospital, because all their stays are gonna be lengthy. So it's very important for you to reinforce self-care and self-image for these patients. That's all. Thank you.
Yeah, they do actually have some snazzy colostomy appliances that I've seen before, with different patterns, especially for kids. They have things that are a little more easily disguised than their clothing. There actually are a lot of options out there. Jumping down to worms in the gut. So this can happen through or can happen through oral ingestion of contaminated food, drink, or other fomites. Pinworms are the most common, and I will say, keep in mind your geographical location, because that can be a big indicator of what your risk factors are. These tend to be more common in children than adults, but also don't rule out adults, especially ones that are maybe hunt and fish more. Fish actually carries a ton of worms in it, most of which are actually fine to consume, but you don't have to, but if you're trying to be very nuanced in your understanding of foodborne illness, you should familiarize yourself with any freshwater fish and or land animals in your area that contain worms that are potentially infectious. On assessment, these patients tend to have nocturnal perianal itching, insomnia, restlessness, and some vague abdominal pain. So you're seeing this perianal itching as you're passing these eggs that are coming out. The eggs can contaminate toilets, they can contaminate the bed, the kids' underwear, other food. If we're talking about fecal-oral transmission, can infect the vagina and urethra. And one of the ways that they still talk about today for detecting this is placing tape over the anus during sleeping hours. You can actually catch the worms on the tape. So jumping over to the diagnostic test, tape test, cellulose tape placed on perianal area, or finding eggs in the perianal area. Medical treatments, using Entomenth, Pin-X, and you must treat the entire family. Take note of that. You must treat the entire family.
We have a question.
Question?
Why is it nocturnal?
Why is it nocturnal?
Yeah.
I'm not really sure. It's a good question. Let me write it down.
Thank you.
We have another question.
I can kind of answer that. I believe that the worms travel to it's like part of the life cycle. They're spread, right, when it's through the itching mechanism of people touching them, and now they can be spread through contact. But the worms will travel from more inside the GI tract to the anus to lay their eggs, which causes that itching. I don't know. That's my understanding.
At night?
Did you hear that?
Yeah.
No,
She thinks it might be because, the worms, tend to navigate to the rectum where they will lay their eggs.
sure. Makes sense to me. This whole thing kinda gives me the creeps, so.
I think we can all agree on that.
Yeah. I don't wanna talk about perineal itching anymore. But, I wrote it down, so I'll try and, find a specific answer, but, I mean, sounds reasonable. So jumping down to anal disorders, hemorrhoids, anal fissures, anal fistulas, anal abscesses. So let's start at hemorrhoids. Hemorrhoids are varices of the rectum, and I think we mentioned a little bit last week that varices being these kind of enlarged veins. Now, when they're in the rectum, they can cause bleeding, discomfort, very, very, very uncomfortable, as I'm told. Etiology can be constipation and also pregnancy. So if you have patients who are chronically constipated, you can develop hemorrhoids. Symptoms, kind of like we discussed, pain with defecation, rectal bleeding. Typically these patients are prescribed a high fiber diet with psyllium, no straining, stool softeners. Now, I want you to remember that because, one, that's how it's tested. Two, the current body of evidence, when you look at dietary intake related to incidence of constipation, does not correlate high fiber diets with better bowel movements. It's actually the opposite, which is very controversial in today's world. But on the test, you will be tested as high fiber diet, psyllium, things to avoid straining, stool softeners. As a note, one of the things that may happen is manual reduction, meaning that if the hemorrhoid is bad enough, if a physician may try to reduce and or reintroduce that into the body, that does not necessarily work. If it is severe enough, you can have surgery, which may either be rubber band ligation, cryosurgery, to freeze them off, or a hemorrhoidectomy, just cutting them out. If a patient does undergo surgical intervention, they tend to have a kind of a rough post-operative period, but it does get better. Anal fissures are longitudinal ulcers in the anal canal, very similar in etiology, constipation, childbirth, but as a note, because it is a fissure, it can be introduced by trauma, i.e. anal sex. Something to keep in mind. I know everyone's seen crazy Instagram pictures of things that they're pulled out of people's colons and butts. So keep in mind that does happen. It's more common than we think, and it's also important that if this is a suspected etiology, or you see a patient who maybe has come into your ED and is acting very conspicuous about why they're there, try to make sure that you are providing a safe environment so that they feel like they can open up about what's wrong so that you can fix it. Because it can be a big stigma and embarrassment about how something happened, when really we're not here to judge anyone, we're here to help you. And signs and symptoms are very similar: painful defecation, bleeding, stool softeners, fluids, surgery, if indicated. Anal fistulas are a tubal tract extending into the anal canal from an opening located beside the anus. You can see things like anal fistulas. You can see rectovaginal fistulas, which connect the vaginal canal to the rectum, which can be very difficult. Etiology here tends to be infectious in nature, and this is speaking specifically to anal fistulas and not something like a rectovaginal fistula. But you're going to have drainage and potentially pus within the stool, so it's something to be mindful of. So the treatment here typically, aside from treating underlying infection, is surgery to kind of repair this area. May also be they will require wound care afterwards and potentially gauze packing. Anal abscesses, this is invasion of perirectal spaces by pathogenic bacteria, very similar to when you have an abscess anywhere else, in which you have this localized flocculation of infectious fluid, which is developed in a space. And this can come from localized infection, and when we're speaking about the anus specifically, one thing to keep in mind is infected hair follicles, as well as sebaceous glands, sweat glands. When you have people who have thick, coarse hair, they can be at a higher risk. We see something called pilonidal cyst, which isn't uncommon, which is typically above the anus, but can develop a abscess that can get dangerously close to the spine and spinal nerves. These patients can have pretty severe pain, and also in very severe cases can develop difficulty walking and or sitting due to the size and or compression of these nerves. Now, these can heal on their own, but sometimes they will require excision and drainage and or a washout. And speaking specifically to pilonidal cysts, these can be chronic in nature, and as I said, these can become very large, localized infections that need to be surgically removed, and also very painful. Dang it. Actually, I think it's it for this. Fecal incontinence. So this is inability to control your bowel movements. This can be urge incontinence, and this can also be passive incontinence. This can range from a little bit of leakage while passing gas, which happens to everyone. I think there's a good term for that. To complete loss of control of the bowels. Now, this can be more common in certain settings, i.e. if a patient has really profound diarrhea, even the most competent and withered patient can have incontinence just from all the stress and having very severe diarrhea. This can happen from muscle or nerve damage, or it can happen from an intracranial process. Now, one thing that I'll say about this is that, and this is going to be something that comes up again in neuro, if you have a patient who is continent of bowel and bladder and then suddenly is not, that should be an alarm that something is going on. And it can be something as innocuous as where they've gotten very sick and altered, but you should do your best to maintain their normal toileting ability unless it's prohibited by something else. Because, and I've seen this happen where someone comes in, and let's just say that they've had a long, complicated history, they can start to get depressed, they can start to have incontinence of bowel and bladder, not from a pathologic process, but just because they don't want to get up, they've given up, they've become hopeless. So it's very important that if something like this begins to happen, you need to rule that out to make sure that something else more sinister isn't going on. But also, if that's going on, that may be a big indicator that from a psychological perspective, they're not doing that well. And I'll say that that is more common than you think. So jumping down again, more causes of fecal incontinence. So we're gonna kind of break this down a little bit. Muscle damage, this can be localized, that meaning that the anal sphincter may make it more, damage to the anal sphincter makes it more difficult to hold back that stool. And this can happen during childbirth, secondary to an episiotomy. And that's more of a localized muscle damage. You can have nerve damage, and that can be nerves that sense stool in the rectum, i.e. another localized injury. But that can also be when there is damage to the spinal cord. That can be when there's stroke and damages to different parts of the cortex. Constipation, chronic constipation, may lead to masses of dry stool within the rectum. It becomes too large to pass. At which point the intestines can stretch and weaken, which allow watery stool from further up the digestive tract to move around the impacted stool. Diarrhea, and that kind of leads to the diarrhea, but if you have a patient who say has a C. diff infection, they can have such profound diarrhea that even though they were a capable and continent adult when they came in, every time they even move, kind of bear down their abdomen, they have liquid stools coming out. And again, I'm gonna try and drive this home. If you have a patient who is experiencing this and, they are alert, they are oriented, they are very well aware that this is occurring, you wanna make sure that you are doing your best to be supportive, because it can be extremely embarrassing for them. And, I've even cared for young people who said they're, pooping the bed a couple times, every hour or so, and they're just mortified. And, I try and drive home like, hey, this is okay. You can't control this. Really try and create a safe environment for them to be in so that, they feel safe to have this going on, but also are going to remain open to what needs to happen for them to get better. I'm also going to jump down to rectal prolapse and or erectocele. So fecal incontinence can develop if the rectum drops down into the anus and or out of the body, which can occur. And rectoceles, which can develop in women, and this is part of that rectovaginal fistula that I mentioned. You can actually have your rectum protrude out through the vagina. Moving on. Fecal incontinence risk factors: age, female, nerve damage, dementia, physical disability. I want you to remember that there's a risk for impaired skin integrity. I want you to remember that there's a risk for impaired skin integrity, as well as social isolation. And again, going back to the other point, there may be folks who are having this really bad, uncontrollable incontinence and diarrhea, and then they're like, okay, I don't want any visitors, I don't want my friends here, I don't want anyone doing this, or being present for this. And, at which point you have to be very understanding, like, hey, if you need some time alone, if you don't want some people to see you in this state, that's totally okay. But social support structures are very important, and trying to provide a safe space, trying to normalize what's going on to some degree, and then kind of putting some interventions into place so that if something happens, you can provide for their privacy. There will be times where I deal with this in the hospital, and there will be a patient who has this new fecal incontinence, but are very aware of themselves and their surroundings, and at which point maybe I will come in every so often and say, hey, can you say if they have visitors, hey, can you step outside for a second? I just need to check something really quick. and kind of develop this little contract with the patient and say like, okay, this is our plan to help provide for this. And then of course doing anything you can to kind of, even if you need to say disguise the smell. Some people are going to use deodorizers, some people might use coffee, anything to create kind of a normal environment so that these patients can still interact with their support systems in a meaningful way. So looking at treatment for fecal incontinence, this is a pretty wide array of things. So antidiarrheal drugs, we talked about loperamide earlier, as well as Lamodal. These are typically over-the-counter drugs that can be purchased outside. Be aware that high-dose loperamide ingestion apparently has some sort of psychoactive effects, so it may be at times implicated as a drug of abuse, but it's not very common. Now, the use of bulk laxatives can sound a little paradoxical, but if the cause of your incontinence is because of chronic constipation, then improving bowel movements can help. There are some injectable bulking agents, which can be injected directly into the canal. And one of the things that you'll see in this area is there are a ton of different medications that they come out with, and in my experience, they come out with a pretty high frequency as new things are developed. I would say that, from 10 years ago to now, in the spectrum, I don't recognize most medications that we tend to use in the hospital other than things we see over the counter and basic things. So it's something that you'll want to kind of try and stay savvy on if these are patients that you see more frequently. Diet is a big one here. And again, your patients tend to know what works for them. If not, we're going to, see what the physician orders. Hopefully they're going to get gastroenterology involved, and hopefully they're going to get a dietitian on board who's going to be able to talk to the patient, find out what they like, find out what they don't like, and get them optimized, for what's going to help them the best. I'm going to go ahead and jump down to some supplemental nutrition. Now remember, these patients who are having a lot of diarrhea, whether it be through fecal incontinence or otherwise, they're going to need some extra help, they're going to need some extra fluids, we're going to need to consult a dietitian typically to make sure that they're getting everything that they need. And one of the things we spoke about briefly is that TPN may be given, and this can be short or long term. We're finding that because TPN can be kind of rough on the body, we try to avoid it unless it's necessary. But that being said, getting nutrition into patients is very important. I have questions. Okay, I'm going to pause and go over these. Sorry, I did not see these questions earlier. The immunosuppressant, we talked about that. When do you use rectal tubes to manage incontinence? So that's a good question. When do you use rectal tubes to manage incontinence? Now, it depends. Yeah, first I'm going to start off with it depends. It depends on where you are. It depends on the hospital that you work at. For instance, the 3 hospitals that I worked at in Florida, outside of extreme circumstances, we never used rectal tubes on the floor, so we never saw them. Now, here, the hospitals that I've worked at around here, they allow rectal tubes on the floor, no problem. Now, there's some thinking that needs to go into the decision to use a rectal tube. Now, first is that you need to think about the anatomy of the patient as well as the way in which the tube works. This tube is not a small device. It's not huge, but once it goes in, it can be distressing to the patient. So one thing you want to consider is, are they awake? Is this something that I will be able to manage? Or are there other precipitating factors that are going to make me think, hey, this is going to cause a problem regardless of how alert the patient's going to be. So like say in the setting of a really severe decubitus ulcer, then this may be indicated. In the ICU, we tend to use these a fair bit, but we like to, it's not a great practice for when a patient just has one bad bout of diarrhea to go, all right, you're getting a rectal tube, which can happen. We want to analyze this as pragmatically as possible and say, why is this occurring? How likely is it to occur again? And is it having a negative impact on the patient? So in general, if the patient has a wound and they are having severe and frequent incontinence, a rectal tube might be a great option. And in the critically ill patient, if they begin to have diarrhea, remember one, that you need to be able to quantify that in some way. So if it's prolonged and severe, having a rectal tube helps to keep accurate I's and O's if you need to replace that. And also, if you have a patient who's extremely ill and they cannot tolerate turning that well, a rectal tube is going to be a better option, especially if you're having to clean them up multiple times an hour. You would be stunned at how much stool a person can put out of their body. So it's a very kind of nuanced approach, but it also depends on where you are and what the patient needs. Now, please keep in the back of your mind that this can be very traumatic for a patient. And even if you're dealing with a patient who is altered in some sort of way, it may be the reaction to say like, oh, they're altered, they're not gonna care. But I will tell you that because they're altered, that can make it much worse. And I've seen this happen in patients where, they've had this very serious diarrhea, they've had this rectal tube inserted, and then, they just cry, and it becomes this trauma that goes on, and, they may even be very sensitive to it, so every time you have to turn them, and this device moves around, they can start crying and get very upset. So, and this applies to giving suppositories as well. Always think very carefully about what you're doing. Think about how your patient's going to react to it if they're unable to participate. If they are able to participate, give them thorough education. Make sure that they know their options, and make sure that they feel like they are in a safe space to allow these things to occur. Did that answer your question?
Yeah.
Thumbs up.
Okay. Does everyone in there know what TPN is?
Blank look.
Blank looks. Okay. So TPN is something I think I've mentioned just the word a couple times, but I didn't think whether if you all knew what it was or not. Who knows what TPN stands for? Right. So now, from a nomenclature standpoint, you may see this verbiage used to represent something that is not what I'm about to tell you, but TPN typically is a fluid which is made by pharmacy in conjunction with lipids that is used as a way to nutritionally support a patient via IV solution if you're unable to even say give them tube feeds, which can occur. This needs to be given through typically a PICC line. If you are going down the TPN route, it's going to be typically long-term. These compounds are very glucose heavy, and so you have to make sure you're monitoring their blood sugars. If for any reason the TPN is stopped, you need to really watch your blood sugars, but also you may need to start a dextrose type fluid to make sure that they don't bottom out. The formula is, like I said, concocted by pharmacy, so they also add in things like vitamins, different nutritional things, and they also will throw in sometimes certain medications such as Pepcid or other things to help. But TPN is something we like to avoid. I will hone in on early nutrition in patients, even in the critically ill. It used to be the mindset that, like say a patient who has a severe abdominal infection, that putting tube feed into their gut, even if by a even if through like an NG tube, would make it worse because you're giving glucose to any bacteria that may be in there. However, from an evidence-based perspective, the earlier you can begin to feed a patient, the better they tend to do. So that's why even in stroke patients, we don't delay very long. You know, we may give them 24 hours, and at that point, we're gonna probably have a discussion about inserting a feeding tube just so we can get something rolling. So enteral nutrition, jumping back to, you need an intact GI tract to give someone food, even if by an NG tube, but there are other factors which can play into it. You know, I've seen patients who have severe liver injury, who have severe pancreatic injury, and you just can't give anything, or else it'll cause a very severe reaction. Patients with severe acute on chronic pancreatitis as well, sometimes these patients might just end up on TPN because they just can't tolerate having anything go down the GI tract. You can give feedings via NG tubes, you can give them by gastrostomy tubes, you can give them by PEG tubes, jejunostomy tubes, and percutaneous jejunostomy tubes. You're gonna find that in practice, there's about, thousands of different variants, not thousands, that's a little extra, but you'll find that there are a lot of different tubes, and often they are referred to with interchangeable verbiage. So if you hear someone say a PEG, you need to look to assess, is this actually a PEG? You may see different types of tubes that have like a GJ, where they have a gastrostomy tube and a jejunostomy tube. And when you see patients like that, you need to verify how is the physician intending that this be used. Often one may be for meds and one may be for tube feeding. They can have different purposes, and even though there are some general rules of thumb, if I can speak to the physician and say, hey, what are your specific orders for that? I will try and find out. Here in this picture, you can see a couple different types of tubes. Here we have, starting at the top, you have a nasogastric tube. Now, nasogastric tubes come in several different flavors. You can have, regular Salem sump type tube. These days, we like to use either a Dobhoff or an Iris, or one that works with a CORTRAK, depending on what the indication is. One thing to note is that, like a Salem sump type tube is good because you can feed, but also you can place these patients to suction. Whereas if you have a Dobhoff or a small bore, you typically cannot. One thing not pictured here, but also an option, is an orogastric tube for patients who are intubated. That's a very common method we use. Down here at the bottom left, you can see the gastrostomy tube, which goes into the gastric body. Now, I want you to look back at the NG tube and trace it down into the stomach and into the intestines. Now, when you have a patient who's getting feeds, you may hear the verbiage used post-pyloric, meaning that they want this NG tube to go down and past the pylorus of the stomach, especially if they're anticipating long-term feeding. And then on the bottom left, you can see a little jejunostomy there. And like I said, there are several flavors of these types, and it may even depend on the organization that you work at and what they tend to opt to use where they are. But NG tubes, very common and something you will see a lot of, and G tubes, PEG tubes, and tubes. Here's another photo here of a J tube on the right, and you can see how there's this little kind of donut shaped thing which anchors the valve and is able to keep that port in place, because you don't want this moving around, especially if you're feeding someone. And this thing, and I've seen this happen, this thing slips out of the intestinal lumen or out of the gastric body, and next thing you know, you're dumping tube feeding into somebody's peritoneal cavity, and they are going to have a bad day. And they're going to get very, very sick. Here in this middle slide, you see a chest x-ray. Now, this chest x-ray actually looks like it's demonstrating a feeding tube that has meandered to a place where it should not be. You can see this central radio-opaque line that crosses down what appears to be the right main stem bronchus and terminates in the right lower lobe of the lung. People think that this, they'll go, that doesn't happen. This definitely won't happen. I've seen it happen 3 times in the last 6 months, and I've seen 2 pneumothoraxes come of it. So be very judicious when you are inserting these. And then up on the top left, you can see a couple different types of catheters. Notably, there's a Foley catheter, which this one says no balloon, but in some places, it may be the protocol that if a PEG tube comes out, the insertion of a Foley with a balloon to keep that lumen open and patent may be indicated. But I haven't done that in a long time. Here's another different type of tube you're going to see here, and this one's very short, very direct. And these again can be permanent. This is a gastrostomy button. It can be permanent or it can be temporary. Some people may freak out about this, but it's important to clarify what the trajectory is for this patient. But if it is temporary, make sure that you are reinforcing that, encouraging the patient to talk about what's going on. And then a lot of power can be found in educating patients that know what's going on and have a very clear picture of where their care is going, tend to feel a little bit more comfortable. So jumping on feedings, I'm not going to spend a ton of time on this because feedings are a dime a dozen and they change everywhere you go. So we're going to kind of hone in on a couple things. Feedings can be continuous or bolus. Oh, good question. Positioning with tubes is 30 degrees still evidence-based practice. So the answer to that is no, kind of. And this is kind of a hot button topic because there are 2 very specific camps, and I'll draw 2 topics that you will see in your practice. One of them is in terms of measuring residuals. That's camp 1. And the other camp is about the positioning for the tubes. It has been traditionally taught, and when I've taught safety fairs at places that I've worked, we have taught, hey, turn your tube feeding off, your patient's gonna aspirate. But the majority of evidence now actually advocates against it because the risk is relatively low. But also they really, really want to avoid interruption in nutrition if they're able to. So do not be surprised if the places that you work say, hey, you need to turn your tube feeding off, because that is still a very common practice. But the current evidence does not support a risk profile that we ascribed to it in the past. Does that answer your question?
Sort of. I'm more like interested in like if they have to be at 30 degrees the entire time, because that puts a lot of pressure on people's sacrum.
Do they have to be 30 degrees the entire time?
Yeah. Like if they
No.
have a K or an NG.
No, so the patients don't need to be up all the time. Is it a good practice to do that? Yes. And I'll say this because, and this is where I'm going to stray from the evidence a little bit, is that anecdotally, these patients, even though in a normal supine position, might just be laying there and be okay. A patient who maybe say is lying flat and then develops a coughing fit, which can definitely happen, especially if the NG tube irritates part of the back of your throat. You're in a little bit more of a compromised position, but that comes into play now that you're outside of the normal. So in general, do I keep my patients up at 30? Yes. When I lay them flat, do I turn my tube feed off? No, but that's because they're only going to be flat for a little while. The longer it's going to happen, the more uncomfortable I become with it. And do not be surprised if your facility makes it known that you need to turn it off if they're below 30 degrees. All right, jumping back over to feedings. Feedings can be bolus or continuous. Bolus can be high or small volume and can be at varying frequencies. Continuous is my preferred method because I don't want to come and get boluses every couple hours. Now, bolusing feedings can be a nice transition into patients who are able to take more nutrition by mouth. Remember that just because you have an NG tube in doesn't mean that you can't eat food. Just because you're requiring tube feed doesn't mean that you can't eat food. Sometimes it might just be that you're just not getting enough calories in, and you can move through this and say, going from, okay, I'm going to try and eat as much breakfast, lunch, and dinner as I can, but I'm going to keep my tube feeding on, to I'm improving from this standpoint, therefore, instead of having tube feed all day, I'll just have it at night, or moving to, I'm doing much better getting more calories in, and therefore, instead of having it running continuously, I will get a bolus in the morning or in the middle of the day or at a set schedule. Now, nursing care looking for vomiting and checking residuals. As I mentioned, this is a more controversial topic, but by the book, you should be checking residuals and holding them if they're too high. Too high often is defined by the facility that you're at. That may be 250, it may be 500, but again, the current trend is to move towards doing anything you can to not interrupt nutrition. I've been at facilities that will use special, different peptide type formulas that are more easily digested, changing different tube feed formulas to see what's working better for a patient, or starting motility drugs to help move things down the line. They'll do just about anything they can to stop it. And the trend that I've seen is now, even if it's above 500, we typically don't stop it because the body tends to compensate for it and adjust to it over time. That being said, if your patient vomits up tube feed, you should call the physician. You should stop it and call the physician. if you feel like your patient is getting more and more and more bloated, you should touch base with your physician. And this is where things get a little hazy, because the evidence now is pushing towards not checking residuals, but I will counter with the not checking of residuals, even though statistically will typically result in a outcome that's fine. When something does go wrong, it can go very wrong. Let's take a 5-minute break.